But great for you all to be joining this Friday report out. I'm Paul Jones. I'm a Chief Digital Information Officer. And yeah, one of the things I look forward to each week is trying to join these calls. So looking forward to all of the stuff we've got lined up. The first one just says AMS. I'm not quite sure who is that. Is it the whole of AMS are here? Is that? I don't know who's leading on that.
That'll be me. So I'll kick things off. So hi, my name's Tom. I'm one of the improvement specialists within the KPO team, and we were asked by the AMS senior leadership team to do a Kaizen event on the Peritoneal Dialysis service. So as part of the Getting It Right First Time recommendations, the service is expected to increase by 20%. So there was a big ask on the service to increase the patient base that they're seeing. So that's the aim of the event, is to achieve that, which is next slide, please. So part of the project form on the ask that we had from the senior leadership team was to increase that capacity by looking at the pathways currently within the service to try and make them more robust and more streamlined and efficient. We were able to map a lot of those out. Next slide, please. Oh, next slide. Thank you.
I was just
no
trying
problem.
to meet somebody.
So this is the value stream map that we built prior to the event. We were able to look at certain aspects of the workload within the PD service, and we broke it down. The triangle on the far left represents the total amount of patients within the service, which is what we're wanting to increase. 42 representing the amount of patients within the PrEP, and then the 72 with the current established pathway. As we can see from the cards above, these are the observations that the Kaizen team had for opportunities of improvement within the service, which we'll go into through our PDSAs. So next slide, please. We have a significant amount of baseline measurements which we're able to obtain whilst going through the service. So I won't go through each of individual ones, but we will cover them whilst we're covering the PDSA. So we're able to establish what the service looks like within its current state, and then through our PDSAs work through to improve that, which we'll be able to go through. Next slide, please. This is a representation of the data that was collected by KPO. So the top left picture with the green and the yellow represents the flow of information within the department. As we can see, there's a significant amount of green, which is all value add to the patient, but within different locations of the department, making it difficult to access for the operators, which are represented in yellow. We were also able to accurately represent how many patients the team needed to see and the amount of time that they needed to be seen in through our TAC time. The numbers through Monday to Sunday represent the median times through May that the patients is seen and scheduled. So we can see that we were going over our patients by 8. We also asked the team prior to the event how they found the service and its current pathways, which you could see there's room for improvement with it currently standing at 2.7. Next slide, please.
Hello, my name is Kirsty from the KPO team. We were in a unique position with the PD team as we had tested some of the concepts in the new KPO event scoping tool. The results showed that the KPO events, the results showed that the PD team's culture was good and they were ready to make improvement. This enabled Tom and I to challenge the PD team to speed up the process. Next slide.
So I'm Angela Hardy. I'm the process owner for this KPO event. Our first PDSA that we came up with within the team was regarding electronic diaries. Currently in the unit, we use 3 different paper diaries that are scattered up and down the unit. Our timed observations that we did within the unit showed us that we were spending around 70 minutes a day wandering up and down the unit looking for these diaries to be able to do our work. I think that the morale of 2.7 shows a true reflection of our frustrations of not having all that information at hand when we need it and having to wander around for 70 minutes trying to do that. The defects that this showed us was that when we looked at our paper diaries for the month of May, we had actually made 60 changes to visits and appointments. So that was 60 changes to patients. The defect with that is that we could potentially lose patients to follow up, having moved them so many times out of the clinic. Next slide, please.
Hello, I'm Darren Gain. I'm a charge nurse on the PD team. So second PDSA we looked at was medication changes. Initially looking at the MDT, but we extended beyond that. We identified that our current practice of printing off medications and prescriptions and sending to the GP is both time consuming quite time intensive, and several processes and people are involved in it. We built a PDSA to improve and streamline this process. After testing our new system, this reduced potential deficits and had a marked time reduction, freeing up time to do other things. We'll also try and utilise this same process within other prescribing within the team to improve safety and enable information to get to the GP sooner. Next slide, please.
Hello, I'm Penny. I'm one of the walkout from PD. This is PDSA 3 on the huddle. This is regarding staff feeling supported during the clinic setup. At present, the staff feel that there are some communication issues during clinic setup, which are leading to defects such as low or non-stock items not being identified in a timely manner, and tasks that are to be completed on both a daily basis and throughout the day during the running of the clinic. This can lead to duplication of some tasks, and there is no standardisation, which can lead to low staff morale. We feel that the introduction of a new leader on point, which will be the staff nurse running the clinic on the day, would alleviate these defects, such as overproduction of staff time completing the same tasks, ensuring the daily tasks are completed in a more timely manner. It would also create a feedback loop for any concerns that need to be addressed or escalated. Staff can also have a second quick sprint huddle after lunch with an update of progress and any further concerns that may have risen, ensuring the staff are well supported. Next slide, please.
My name's Stephanie and I'm a senior clinical support worker on the peritoneal dialysis unit. Today I'm going to talk you through the PDSA 4, which is walk-in setup reduction. It was identified that the peritonitis walk-ins was taking up most of the time to prepare and set up, taking on average around 15 minutes to collect the equipment and print off the blood forms, therefore impacting on patient waiting times. Having identified this as an area that we could improve, we have now implemented a system that we have 2 pre-paired packs already set up, reducing waiting times by 10 minutes. Next slide, please.
Hello, my name is Gina. I'm one of the PD nurses. So what went well on this training? It has brought us more opportunity for continuous change. There was a safe space to have difficult conversations. We worked well as a team and everyone contributed. The PD team for a while had a chance to sit together and have the headspace to think about what the improvements we want to make. And also a quote from Dr. Dolph Mogendorf, patient partner. He stated that the commitment to improvement by the whole team showed in the way all contributed and willing to challenge each other in a meaningful way with an excellent initial outcome. Next slide, please.
Due to the sheer numbers of ideas generated, an improvement board has been created on a visible electronic platform. A programme of improvement work for the year is being put together, which allows for further improvement ideas to be submitted to ensure continuous improvement in the PD service. Next slide.
So what we could do differently? So group consensus was the training was invaluable and will be beneficial to improving the way we work and finding time that we need to meet the demands. The only thing we highlighted that could have been done differently is potentially at the beginning discussing the expectations of the team and highlighting that not all issues that we come up with could be addressed in the 3 days training. However, obviously we have reviewed the subjects that haven't been reviewed yet. We've added to the improvement board so we can look at these at a later date or integrate them with some of the other things that we've done in future. Next slide, please.
And we'd just like to end with a few thank yous. Huge support from the Tri team, which has been amazing, in particular with Mark Richardson, who's been fantastic, who've removing barriers in flow for us during the event. Also the senior leadership team who've been covering PD to allow us the space to be able to take the team out whilst continuing the service. Vince, the business manager, who's able to provide us with that data, our patient partner Dolph, the home team who aren't here currently in report out, but who were also partaking in the event, and also Graham and Vicky, who were our consultants. So a huge thank you to everyone. But that's everyone for us. Thank you very much.
Thank you.
Wow, it's a fantastic piece of work, and yeah, I mean, I think you're right. Generating so many ideas, you can't do them all, can you? But kind of recognising that and making sure you don't lose them and can address them in the future, I think that's fantastic. Just really conscious we need to move on. So, Nicole and Iona, are you here?
Yes, hello. I'll launch straight into it. So, hello, my name's Iona Norman. I'm a senior learning practice facilitator, and there's two of us presenting this programme today. I'll let Nicole introduce herself.
So good afternoon, my name's Nicole Boardman. I'm also a senior practice learning facilitator.
Hello, so today we are, our title is Practice Educator and Assessor Preparation Programme. So this is a training programme used for the transition from practice supervisor to practice assessor out in the ward areas, and it aligns to registered nurses and registered nursing associates. Allied health professionals and midwives aren't in this process because they have their own processes. So our aim today through our project is to create 80% of registered nurses and registered nursing associates to be practice assessors qualified to each placement area. And to do this, obviously, we would need to improve our delivery process already, which is our PEAP process, to align by increasing programme uptake. We realised very quickly this was a huge project, so felt that utilising LIM would help us to structure our change management processes. Next slide, please. And so our problems and challenges. So existing process was admin heavy, duplicate emails. We could have done a spaghetti diagram, but you wouldn't have seen it because of the thickness of the trails. No obvious pathways for newly qualified RNs or RNAs, registrants new to trust. Our data collection, we have to collect from multiple external systems, which is problematic in itself. Our current numbers of qualified practice assessors currently stand at 37%, which is nowhere near our 80%, and our uptake of PEAP to meet the demands of learner capacity in the trust. So our current position is that we deliver from in last year from June 24 to June 25, capping, we deliver one monthly, we're capped at 40. We delivered 60 children's, which aligns with their preceptorships. We delivered 317, for adults, which was a total of 377 for the year, which, as you can see, is never going to help us reach our targets. Through utilising the LIM, we have linked the 7 Cs, clearly quality. By providing quality placements, we need to ensure that our staff are suitably prepared, and our resources, utilising trust platforms to streamline our process and reduce our waste. Next slide, please. So our actions, we used a process flowchart initially for the current PEAP process, just so that we had a visual that we could look at. We then moved on to an affinity diagram. We actually utilised the KPO team, and the whole team arrived to complete our affinity diagram. We looked at the PEAP process to capture all the ideas with the team and identify themes and focus on areas of change. So we also identified 3 PDSA cycles. The project in itself was far too big to deliver for LIM, so we broke it down into PDSA cycles. So that was to improve delivery of PEAP, the programme uptake, which would align with the 80% KPIs, and new to trust process, which aligns with preceptorship. Stakeholder engagement was absolutely key for what we are doing. So we involved the postgraduate professional development team, and we had discussions with SAPIMed and all the clinical areas as well for their input. So from that, our identified aims are to streamline PEAP, the PEAP booking process to reduce admin. And we did that by developing a driver diagram to make it really clear how we wanted it to look and how it would look for the future. And team engagement, so we developed a rating matrix to clarify roles and responsibilities. Again, such a big project, everybody needs to be involved in it. Next slide, and I'll hand you over to Nicole.
So our outcomes that we were able to achieve in the time that we had. So at the minute, we've currently rolled out ESR bookings for our PEAP programme, which have commenced from last week from October bookings, and that's for the year. And we've already had positive feedback regarding the accessibility for staff and the uptake already that we've seen. We now have the ability to pull reports for specific CSUs in each clinical area, which makes it more accurate for us, because previously we had multiple booking systems. And then we've been able to reduce errors in bookings. Previously we had errors as far as PS non-compliance, so they weren't completing the mandatory practice supervision preparation. incorrect registration. So we had people from different registrations booking onto the course, and missed emails for bookings, which made the admin trail quite heavy. We've now been able to build it into the trust preceptorship, so it's a requirement for newly qualified and anybody new to the trust to complete it before their 12 months of sign-off, and this is now recorded on ZappyMed. So our outcome measures, we do monthly KPIs within the team for PA figures, so practice assessor figures, and they're reported individually by each PLF within the team and for each CSU, and these will be more accurate for us going forward. And these KPIs will be reported by our leads to via MMAP. Next slide, please. So what went well? We found this a really difficult challenge. Like Iona said, it was such a big project when we started, but it enabled us to work as a team collaboratively, and the outcome that we've achieved, we're really happy with. There's still a lot of work that we want to do as far as the programme, but we're happy with what we've done. We've been able to embed it into the preceptorship programme, which is really positive for us, and streamline our booking process via ESR. And it's now structured for new starters, so they understand the pathway and how to book on and how they become a practice assessor within the trust. And this will aim to reduce our admin time, which hopefully we will see going forward. Next slide, please. So what would we do differently? Like Iona said, we wouldn't approach the project as such a whole because it was so big for us. So next time we'd probably look at aspects of the process that we can focus on. So our next steps for improvement are to review our assurance process for when people sign off as practice assessors of completion to ensure that they are ready and suitable to support learners within the trust. Our proof of completion via ZappyMed, which is not built in yet, which is an ongoing process at the minute, and then embed our KPIs into a perfect ward, hopefully, so they're part of the ward metrics. And utilise ZappyMed for our existing registrants. So obviously everybody in the trust are doing preceptorship that are new to the trust. However, we want to capture existing staff members within the trust onto ZappyMed so the skill passport is updated. Next slide, please. And that's it. Okay.
Thank you.
Thank you for listening.
No, that was super. And I think some of the other commitments in there as well, kind of using existing things we've already got to improve your processes rather than trying to invent new things, using the preceptorship, using a technology that was already there. I just love that, kind of standardise and simplify, make things repeatable. When we're this big as a trust, simplifying and standardising are always the way to go. So that's a great kind of lesson there. So thank you both. I'm sorry I'm rabbiting on, Sarah. We're cutting into your time. Do you want to take over?
I will do. Good afternoon, everybody. My name is Sarah Rogers. I'm the Improvement Lead for Volunteering. I work as part of the Patient Experience team in the Chief Nurse CSU. And my project was around how can volunteers enhance patient experience in the emergency department at St James's and increase feedback left by patients via friends and family test. Next slide, please. So the problems that we encountered were, we knew from the themes that we recognised in PALS and complaints and through our national patient survey that patients weren't satisfied with communication, didn't always feel listened to. There were concerns over access to food and drink, and we knew that our friends and family test or FFT response rate was below the national target of 20%. So we set ourselves the challenge of looking at how volunteers could support in enhancing patient experience in ED, but also to help us understand what the experience was to drive up the FFT response rate. Just in terms of how this linked with the Trust strategic priorities, we do have a volunteering strategy, and our ambition for that is that we strive for excellence in volunteering in the NHS. Obviously, access to food and drink linked nicely with the Nutrition Mission campaign that's been launched across the organisation. And although when we launched this, we were looking at last year's 7 commitments, there wasn't as much affinity. This year, definitely, this hits the quality, compassion, but also as I go through my slides, you'll see how we had a sort of a knock-on impact on resourcing and team. Next slide, please. So just in terms of those initial actions that we've taken, we worked really closely with Kirsten Leach, Head of Nursing, who was fantastic support and helped us co-design the role profile. Obviously, she knew better than anybody the challenges of the department, so was vital in helping us create that role profile. This hadn't been part of our annual work plan, so we planned an extraordinary round of recruitment to address the need for this. and we identified a volunteer to help us pilot the role. We were really keen to test this and get it right for volunteers and for patients. Just in terms of some of the LIM methodology, we used a production board to manage the recruitment side of things. We carried out a visit to the department several times just to understand how it might be different at different times of the day, what volunteers could expect to encounter, and to understand better the challenges that patients were expressing to us. And we used PDSA to absolutely tweak the role and get it right for volunteers, and we listened to staff feedback. Just in terms of engaging the team, I'm not taking any credit for the work and the improvements that have been made here. This has been driven by my team, and they've been really keen to innovate and come up with ideas of how we can deliver this and try and seek some improvements. We did communicate really effectively around this. Frequent huddles and linking in with the staff team in ED was really vital, but also making sure that volunteers could feedback to us freely, and reflecting on the data that we had available to us was really key. Next slide, please. So just in terms of the outcomes, obviously for us, we are really interested in what the volunteer journey is like in all of this. And through the round of recruitment, we recruited 18 volunteers in total. And the process saw us reduce our average recruitment time from 42 days down to 36. We only have data for one complete quarter, which is Q4 for the year of 24 to 25, and 170 volunteer hours were gifted in that period. But we know for Q1 of this year, we're already in excess of that. So the hours that have been gifted are increasing. And we do capture volunteer feedback after each shift. And this is just a little sample of the things that volunteers tell us about their time in the department. So just in terms of patient experience, I've mentioned that part of the ambition was to increase FFT feedback. And with the comparable period of 23-24, we know that feedback left by our iPads in ED at St James's increased by 15%. So it now sits at 18%, which is much closer to that 20% target. And there's been a 4% increase in the positive feedback that's been left. We've captured some really lovely feedback from patients via FFT that clearly recognise that volunteers are making a difference to their time in the department, whether it be providing refreshments or whether it's just giving them that supportive welcome and getting them to the right waiting place. Just in terms of staff feedback, again, I've said that it's really important that staff were on board with this and supportive of the initiative. And as part of our annual staff survey, 100% of staff agreed that volunteers play a positive impact on patients and visitors. 100% of staff would recommend having volunteer support in their team. And I think really significantly, if we think about the financial impact, on average, staff tell us that when there's a volunteer on shift, it can save them 2 to 3 hours of their staff time per shift. And if we add that up with the current number of volunteers and shifts that have been fulfilled, that's saving us around 11,000 hours of staff time per year. And I mean that in terms of that frees up staff time so that they can get on with their job, not to replace staff time. So next slide, please. So just to highlight what went well, this is Nigel, our Uber volunteer. He's an absolute dream and he does multiple roles with us, but he was kind of our buddy volunteer. So he was the one who tested it for us, and then he supported all volunteers through their inductions into the area and was really vital in providing feedback to the staff team and to our team in terms of what was working well and what wasn't. I've mentioned already that Kirsten created a really good culture of how we work with volunteers in ED, so that was really helpful. And just in terms of the use of technology, we revamped some old iPads that were available in the department so that volunteers could use those specifically for capturing that FFT feedback. And again, I've already touched upon the good communication that was required to get this right. Next slide, please. So just in terms of what we do differently, I think this has been a great learning curve. Using a confident, experienced volunteer as a mentor was brilliant, so that was really good. But building capacity in for that as part of the project is important. I think there's value in having some face-to-face inductions so that, again, volunteers are confident and they've got that opportunity to ask questions and any queries that they might have. I think capturing data throughout is really important. We're fortunate enough to have the patient experience data at hand, but again, just getting that snapshot feedback throughout the project is really important, and probably something that we'd build into doing a bit more periodically going forwards. What's next? Our ambition is to absolutely sustain the numbers and grow them in ED, because we are seeing the benefits, and definitely to use the model of having a buddy system into some new roles that we're introducing, such as our mealtime support role that we're rolling out shortly, and to ensure that we're embedding some of the methodology that we've learned into our everyday way of working. And on the right there is just a little word cloud, and this is from our volunteer feedback when we ask them to describe volunteering at LTHT in 3 words. That's everything from me. Thank you.
Thanks, Sarah. Great to see those improvements by patients and the volunteers. Angela.
Hi there. So my project that I was looking at was about, sorry, I'll just introduce myself, Angela Padusha. I'm a sister on G54 adult critical care. So my project was about looking at how we can reduce the amount of stock that's wasted when we're doing an end of patient stay in critical care who's been in a source isolated room. So my project aim statement was to reduce the amount of stock wasted by 25%. So next slide, please. So I looked into this project because observations had highlighted that a large amount of waste was created due to overstocked bedside trolleys. So just to give a bit of background, in critical care, each bed space has a bedside trolley with 4 drawers in, which has all the stock that a nurse is likely to need at that bedside. So syringes, needles, given sets for pumps. And when the patient leaves, if they've been source isolated, everything needs to be thrown away. So if the trolleys are overstocked, it leads to a large amount of waste. And there was a lack of consistency about the correct process to follow. So some people were throwing everything away and other people weren't for specific infections. We had a green competition within our CSU, so I submitted this idea into this competition and this idea won, so that sort of gave me the push that it was something worth pursuing to look into. It's specifically linked to the 7 commitments. This was last year's commitments, 24-25, and it's specifically linked to sustainability and finance. And supported the Leeds Teaching Hospital's green plan of reducing plastic use as part of the GRASP campaign, because most of the equipment on the bedside trolleys is plastic based. Next slide, please. And this just shows an example of the amount of stock that gets taken into the side rooms unnecessarily and leads to a large amount of extra cost. But it's also that plastic waste that concerns us as well. So this is what we were trying to help with this project. So next slide, please. So the LIM tools that I used was, our unit is split up into 3 different areas. So I focused my project on J53, which has 2 side rooms at one end and then a 6-bedded open bay. So I did some direct observations and it highlighted the time that it takes to go to the stock room from the side rooms, which are at opposite ends of the unit. So that led to an instant improvement because we got a new stock trolley that was just outside the area of the side room for easy access to supply. So just one simple improvement was really positive. Did the 5 essays as well, looking at the current stock list on the bedside trolleys, and that led to a reduced stock list that were laminated, attached onto the trolleys as a clear guide to follow when setting up new bed spaces, so that everybody knew what was meant to be going on the trolleys. I had great engagement from the team. The CSW team, they're the workforce who predominantly are removing the equipment and stock from the side rooms when a patient leaves, and they're the ones that were highlighting about the amount of waste that we were creating. Mental valleys, what I did find was difficult to find answers about what can be cleaned, what could be reused. So that took a bit of digging just to be able to get the answers that I needed. Next slide, please. So the outcome you know, how we made improvements. So raising awareness of what we can do to reduce waste. So, for example, the poster displaying that about the amount of waste, a bit of education amongst the team. Not everybody was aware that everything needed to be thrown away at the end of a source isolation clean. So that in itself makes people think a bit more carefully about the stock that is taken into the side room. I did send out a Google's form with some questions as well, so only 42% of the staff knew that all the stock needed to be discarded. The metrics that I had to show some improvement, well, I had the staff walking distance, so the reduced time spent walking to the stock room. And again, in my Google Forms, 78% of staff said the stock trolley had really helped to reduce waste and time. The difficulties I had really was measuring the waste at the end of a patient's stay to quantify the cost saving and sustainability. And part of that has been the area that I focused my project on J53. It's been periodically closed, so I've really struggled to get that improvement of when a patient leaves, whether it has led to an improvement. So that is a bit of an ongoing project for me. Next slide, please. So what went well? I think with an immediate improvement with the new stock trolley, real positive engagement within the team, and I got a lot of good ideas on waste reduction raised in my Google Forms questionnaire as well. And we got some clear guidance from IPC regarding what needs to be thrown away at a source isolation clean. Next slide, please. What would I do differently? To keep focused on the project, I think that was a big learning thing for me, because it kind of put something in place, move on to something else, and I've missed capturing the cleans at the end of patient stay and keeping the team engagement going with something as well. And I really want to roll this improvement plan out to other side rooms on 54. And I think on reflection, you know, it maybe would have been better if I'd focused in an area where we had more side rooms, so that the problem with 53 being shut quite a lot of the time has made my project a bit difficult. And looking into options to recycle plastic waste, but I haven't looked into that already. I think because it's clinical waste, it's very difficult to recycle, even if it's not being used. And I think, is that the end of my presentation now? Yes, thank you.
Thank you, Angela. That was fantastic. I know we're doing something recycling with the asthma inhalers, which are plastic waste and clinical a bit. I mean, perhaps not as clinical as some of the stuff you've got. So there might be some things we can do there. But no, brilliant progress, and good to see you looking at other areas that you can share that learning in as well. That spreading the scale across the trust is one of the really important things we've got to do with improvement. So I'm just really conscious we've kind of run over actually, so no time for questions, but thank you to all the presenters today. I know Jenny popped in and popped out because I know she's got a 1 o'clock, but thank you for all your work. Thank you for all of that focus on the Leeds improvement method, and hopefully see some of you next week. Thanks everyone, take care, have a lovely weekend.
Thank you.
Thank you. Bye-bye.